Okay, good evening once again. My name is Dr. Nganga, and we are privileged today to have a very interesting presentation entitled The Complicated Intra-Abdominal Infections, and we shall be looking at the current concepts. Our presenter today is Dr. Reuben Okioma. He's a practicing surgeon at the Nairobi hospital, and he's also an intensivist. So we're very privileged in the sense that we'll look at this topic from those two perspectives. I can see the numbers have really gone up, and it's 6:05. So without any more ado, I'll want to invite Dr. Okioma. Karibu daktari.
Thank you, Dr. Nganga. I hope you can hear me clearly.
Yeah, we can hear you, Dr.
Thank you. Thank you again for KSA and CCSK for giving me this opportunity to share with us this discussion on complicated intra-abdominal infections and look at what are the current concepts. I'm going to present a case that we managed not long ago at our institution, and we're going to use this for our discussion this evening. We managed a 52-year-old female, para 3+0, who had a background of hypertension, and she was admitted on the 18th of March. Initial diagnosis was symptomatic uterine fibroids. She had anemia of 9.1, and she was planned for an elective transabdominal hysterectomy, which was done on the 19th of March this year. About 4 days after the surgery, she developed abdominal distension with vomiting, fever. She had reduced urine output, and she also had associated difficulty in breathing. A quick ultrasound was done, which showed intra-abdominal fluid correction with debris. And initially it was thought that being post-TAH, that she likely had injury to the genitourinary system. A CT pyelogram was planned, but what was done the next day was a CT scan of the abdomen and a CTPA. This showed bilateral subsegmental pulmonary emboli. She had pneumoperitoneum, likely from the surgery. She had significant fluid collection in the pelvis with debris, and there were also multiple air fluid levels. Remember, as I said, she was also vomiting. So on the 24th of March, she underwent a laparotomy. This was done by the general surgeons, and they found foul-smelling, bloody pelvic correction. There was a gangrenous pelvic stump, and there was also, there was no visceral perforation. And because of her state, she was admitted into the ICU in septic shock, that is post-op. We put her on inotropic support and started her on a broad spectrum antibiotic, that was meropenem, after a blood culture sample was taken. At this point, her CRP was quite high, 314, a procalcitonin of 82, and her urea was also quite high, 15.2, and a creatinine of 302. So she was in septic shock and also had AKI, and this was related to the sepsis. We had a renal review the same day. We started continuous renal replacement, and she was started empirically on tigecycline. That is before we could get our cultures back. On the 27th, her wound was noted to be septic with foul smell or foul smelling discharge. We released a few stitches just to let that effluent flow out. And by the 29th, she still had fevers. A repeat ultrasound still showed some light iliac fluid correction. And this despite being on meropenem and tigecycline, which are two quite heavy antibiotics. By The 30th, there was marked improvement. She was febrile. She had better urine output, and we were now doing intermittent conventional dialysis. And we increased her crexane to 40 BD. Remember, she had subsegmental pulmonary emboli, but because of her bleeding initially, we could not put a treatment dose. This was just to increase the dose and, review and reassess. Our aim was to eventually get to treatment doses of crexane. Later on, we increased the crexane to 60 BD. As I said, she was improving, but we noticed worsening in respiration with breathlessness and increasing oxygen demands. By this time, we had already sent her back to the ward. We tried Lasix diuresis because we thought probably she had fluid overload, but that didn't help. At this point, we got the help of an interventional radiologist who did a scan, and this showed bilateral subphrenic corrections with subtated perisplenic corrections. And there was also bilateral reactive pleural effusions. The pleural effusions were drained, and there was also an abdominal correction which was drained, and a pigtail, which this is just an abdominal drain that was left in situ. By the 3rd of April, this is about 15 days since her admission, we got the cultures back, and this was from the fluid that was, gotten intra-op during her second surgery. And this grew serratia macens, which was sensitive to meropenem. And remember, she had been on this since the 25th. It was also sensitive to ciprofloxacin. The wound swab did not show any growth, but the chest X-ray showed increasing pleural effusions despite the fact that we had drained that with the help of the interventional radiologist. So she was de-escalated to ciprofloxacin as it was, the bacteria we grew was sensitive to ciprofloxacin. But by the 6th, we noted her temperatures were still higher, and we grew a Klebsiella pneumonia from a CVC tip. We had removed a central venous catheter that was inserted after her admission into ICU. Her blood culture had not grown anything, and the urine culture had not grown anything. She had a HB of 8.8. This is the culture from the pus swab. This was the intra-abdominal pus collection. And then as you can see, it was sensitive to all the drugs that it was exposed to, and especially ciprofloxacin, which is what we de-escalated to in this case. So let alone, by the 7th of April, we requested the intervention radiologist to review the pleural effusions, and a right underwater seal drainage was inserted. There was also a notable gallbladder fossa correction, which was also drained, and a pigtail left in situ. By this time, the right subphrenic pigtail was not draining much, so we removed. We transfused her because her HB, as I said, initially was 8, now had gone to 7. We repeated the CT scan, and this is because she still looked quite ill. And there was still a large subphrenic abscess, and this abscess is now had extended into the liver with obvious features of peritonitis. And the bilateral pleural effusions were still there, despite being drained with the pigtails. She was now quite diaphoretic. The fever was 38.2. She was desaturating at 92% on 15 liters. And this warranted her readmission, reintubation, and also we repeated septic screens. By this time, we had a diagnosis of failed treatment with the initial antibiotic choice. So we opted for ceftazidime and Flagyl, and this was after adrenopalastomy. What was notable is because of significant adhesions, the surgeons were not able to access most of these past corrections. So despite that, we were able to extubate her on the 11th. She tolerated the NRM quite well. However, she got delirium by the 12th, which responded quite well to haloperidol. And by this time, she was hypertensive. Remember, initially, she was hypotensive. We noted also the repeat CVC we had inserted had also developed signs of sepsis, which we had to change. By the 13th, we reintubated her because she was not doing any better. We noted also her abdominal wound was still septic, but it was much better. At this point, her antibiotics were changed to tazocine and amikacin. As she was still febrile, her CRP was still quite high at 234, although her procalcitonin had come down to 1.4. We also were keen to look out for fungal infections. Remember, she had been with us for quite some time. She had been on TPN for quite some time. She had had lots of antibiotics. And we actually got candida in her tracheoaspirate. And the fact that she had pneumonia, we were justified. And we started her on micafungin, which is a fairly strong antifungal. She stayed with us for another 4 or 5 days in ICU. By the 15th, we still had another intervention or radiology drainage of intra-abdominal pus correction. By the 16th, we grew Klebsiella pneumonia on a catheter tip. And by 17th, she had overt ARDS despite being on the vent. We also thought she had overloaded on fluids. So by the 25th, she stayed with us for another 2 months. By the 25th, most of the drains had been removed. She was now on enteral feeds. She had grown candida in blood, but we were on micafungin, so we still continued with that. We removed all the CVCs and we removed the CVC and inserted peripheral inserted central catheter, not the usual CVC. She still grew MDR Klebsiella on the chest drains. We were checking the chest drains once we were removing them. And these were only sensitive to meropenem and coristin. Remember, coristin is really the reserve drug that we have currently for these MDR infections. But after a day, we got sensitivity back. And the sensitivity was good for tigecycline. So we went back on what we had her initially on, and that was tigecycline and meropenem. By the third, she was stable, extubated, her renal function had normalized, and she was not on dialysis. We stopped all antibiotics by then, and she was discharged to the general ward. However, her surgical wound was still fairly septic, superficial sepsis, and we had vac dressing applied by the plastic surgeon. And significantly, it was non-eventful hospital stay until she was discharged. She was discharged around the 28th of June, but stayed with us a little more because of the bills. So this was the fungal culture. And as I said, it was quite sensitive to micafungin. We chose that, and we were not very keen to start her on fluconazole because there's been shown to be significant resistance of the candidate to fluconazole in our setup. And this was also a very sick patient. This was the culture of the blood that I described that also grew candida, and we were using micafungin during this time. This is the catheter tip I also mentioned, and this only had tigecycline as the only sensitive drug. This is towards the end, and that's why we went back on tigecycline. We used meropenem in addition to the tigecycline as a synergistic kind of boost because we realized this lady had very resistant bags. That's the catheter tip I mentioned. The E. coli was from the abdominal wound. And as you know, it is quite sensitive to the usual drugs that we probably have access to in our setup. I hope that's a brief history of a typical case scenario for complicated intra-abdominal sepsis. Allow me now to discuss a little about what these complicated intra-abdominal infections entail and what we can do, or what are the current concepts in how we can manage them. First, we know that the sepsis, and we know sepsis is a systemic process. And what is significant is that there is organ failure resulting from a dysregulated host immune response to an infection. Our infection in this case is intra-abdominal. This is bacterial peritonitis. Our patient had secondary peritonitis, which resulted from a surgical procedure intra-abdominally. It proceeded to tertiary. Remember, we also had lots of other interventions while she was with us in ICU, which could also lead to this kind of tertiary peritonitis. Intra-abdominal sepsis, especially when it complicates, has a very high mortality of up to 70%. And this is in situations where you have multi-organ failure. Abdominal sepsis is the second commonest cause of sepsis-related mortality in the ICU, and that is after respiratory or pulmonary-related sepsis. There are several studies that have tried to look at complicated intra-abdominal infections. One of them is the Sierra study, and this looked at about over 2,000 patients who had complicated intra-abdominal infections. This is all in Europe in the year 2012. And the overall mortality was 7.7. This looks quite low as compared to what we know as the global numbers. They, however, looked at a few subgroups, and they found that those who had severe sepsis and septic shock at admission had a much higher mortality of that 2.4. And those who had postoperative shock, sepsis and shock, their mortality was much higher, 42.3%. Our patient had this kind of sepsis. Remember, we had actually 2 abdominal surgeries. In terms of epidemiology, several studies have been done. The most recent one is the one looking at the epidemiology of complicated intra-abdominal infection and sepsis in critically ill patients. This one was looking at critical ill patients in ICU in about 309 international centers in the year 2016. And what they found is that 2% of those who had complicated intra-abdominal sepsis were from the community, but 68% were in the hospital setup. Some early, 25%, and late was 43%. Our patient presented within 3 days of the initial surgery, so this looked more like the early onset. Organ failure and septic shock were more frequent with hospital-acquired infection, and this also happened with our patient, especially after the second surgery. In this group of over 2,000 patients, secondary peritonitis, which is in most cases related to surgery, was 68%. There was biliary tract related infections at 12%, with intra-abdominal abscesses being 7% and peripancreatic infections being 6%. We are going to look at the commonest pathogens, which is quite common, or which are quite common in the setting of complicated intra-abdominal infections, and most of them are gram-negative pathogens with the very few gram-positive. I do hope you can still hear me clearly. Idris?
We can hear you, Doc. Just go on.
Thank you. Don't forget also about fungi. Fungi are also quite common, and with our patients, because of the prolonged hospital stay, she ended up getting a fungal infection. Multi-drug resistance, like happened to our patient, is also quite common. And this is also related to what we use in terms of antibiotics.
Dr. Okioma?
Yes.
Oh, there's a problem with your slides, but now I can see the back. Right.
Yes, I've noted it's a little slow. You can see the slide well now?
Yes, we can.
Thank you. So what is the take-home message in terms of epidemiology is, despite all the advances we have had in ICU care, surgery, and all that, the mortality is still quite high, 24 to 34%, of course, depending on which authority you look at. And this is also despite the fact that we have improved source control and also improved our antibiotic usage and choices. Sorry, I think I've missed one slide there. Not sure why, but looking at the risk factors to intra-abdominal sepsis, this can be both hosts and also factors related to our interventions. In terms of hosts, we know there's a genetic predisposition to developing severe sepsis. I know currently there's a big team in the UK that is looking at the role of genetics in sepsis. Not everyone who gets an overwhelming infection eventually gets into severe sepsis and shock. Increased age, this is pretty obvious. The defenses are quite low at this point, and any acquired immunosuppression, cancer, medication, diabetes, and also alcohol use. In terms of surgical complications, the risk factors to anastomotic leakage are going to increase the chances of getting a complicated intra-abdominal infection. And here we have male gender, of course, advanced age, history of smoking, intraoperative hypotension during the surgery, and medications which would affect wound healing, like steroid, corticosteroids, and diabetes mellitus. Several studies have looked at pulmonary infections and their relation to complicated intra-abdominal infections, and COPD is thought to independently contribute to complications within the abdomen. I'm not sure why this is the case, but could it be related to hypoxia? I'm not sure. Prolonged intubation or prolonged surgeries, aspiration, which may happen intra-op, or any recent major abdominal or thoracic surgical procedures. Of course, any indwelling urethral catheters, patient who has poor mobility and the female sex have been shown to also contribute to urosepsis, which in turn is thought to eventually cause an abdominal infection. This is a picture of the intra-abdominal findings in this patient, the initial surgery, that after the TH, that's the second laparotomy, sorry, was significant pus collection in the abdomen. Looking at the microbiology, we all probably remember this from our undergraduates. There's a lot of bacteria, which is of course more concentrated towards the distal aspects of GIT. And these are the same microorganisms that are going to cause sepsis. Of course, there are those that are more common than others, and there are various factors why you may get one, not the other. For example, it depends on which viscus has been perforated, and also antibiotic choices. As I've mentioned, Enterobacteriaceae are the commonest. We get E. coli as being the commonest cause, especially of primary peritonitis. But when we get to secondary peritonitis, then the anaerobes like Bacteroides fragilis are also quite common. When we think about healthcare associated microorganisms, then Pseudomonas, Acinetobacter, ESBL, Klebsiella, and E. coli are very, very common. Our patient had Klebsiella, had E. coli and Serratia. Serratia is not common, but the Klebsiella, E. coli, and Pseudomonas are quite common in our setup. The others, Enterobacter, Proteus, and MRSA, not as common. But as I said, we always have to remember that fungal infections are to be thought of. In terms of the mechanisms of sepsis, the pathophysiology, we know the gram-negative bacteria is through the lipopolysaccharides and the endotoxins. With the gram-positive bacteria, it's the lipoteichoic acid and peptoglycans. And for the anaerobic bacteria, including E. coli, Klebsiella, it's all due to the toxins that they release. In terms of diagnosis, there are a few important concepts to remember. One, we have to reduce the time to diagnosis. Two, we have to delineate the source of infection as accurately as possible prior to the surgery. This will enhance your chances of source control with the fast intervention. And then we need to remember that the diagnosis is quite clinical in addition to, of course, the adjuncts, like the scans and the ultrasounds. And this is even more important when you have critically ill patients. In terms of imaging, these are the basics we have all been taught, sorry. If we are using an abdominal X-ray, we are looking for free fluid under the diaphragm. We are looking for air fluid levels. In this case, these denote paralytic areas of some sort, and this is common with severely ill patients, even without intestinal obstruction. We could say it is an dynamic intestinal obstruction. This, however, we know has low sensitivity and specificity and depends, of course, on how well the X-ray was done. Ultrasonography, quite important, but we know its drawbacks with paralytic areas where there's a lot of gaseous distension, obesity, and we know it is very user dependent. Some of the ultrasound reports you get for the abdomen will be of very little use, to say the least. The advantages, of course, it's portable, it's reproducible, and this can be used at the point of care, even in the accident and emergency departments. With biliary related peritonitis, very important, even in picking up gallbladder stones, which in most cases will be the underlying pathology with the cholecystitis. Abdominal CT scan, quite specific and sensitive. However, it requires you to move the patient from the ICU. If they are not very sick, this is probably the investigation of choice. There has been more evidence of minimally invasive modalities, and here I'm talking about bedside laparoscopy, especially in the critical care setup, where you have a very sick patients, you can't move them to the accident and to the CT scan room for the CT scan. The ultrasound is not giving you much information. Then bedside laparoscopy is a very good option. Of course, this requires movement of the laparoscopic tower from the OR, but it's minimally invasive, and for a very sick patient, this may actually also be therapeutic in that you can drain any fluid collections, pus collections within the abdomen. I've seen this being done, though not in our local setup, and the results were quite good. Just a picture of that. Allow me now to go through the main principles of management. And this is a pictorial representation of the algorithm. There are three main tenets of this. One, of course, is the surgery, or the surgical aspect. This is antimicrobial therapy, and then intensive care. And with intensive care, feeding is very important, analgesia, of course, thromboprophylaxis, ulcer prophylaxis, good sugar control, and all these have been shown to have an effect on outcomes, and also in preventing our patients deteriorating into multi-organ failure. Remember, we always have to reevaluate our patient. Even after having done a laparotomy, we have to consider, do we need to do a laparotomy or not? And with this, we have adjuncts that you can use, whether it's the ultrasounds or the CT scans. And if you are able to do image-guided intervention, then it will be very useful, more so with the very sick patients. How is the intensive care useful in managing these patients? Most of the patients we get into the ICUs, there's evidence that they have had some suboptimal care while in the ward at some stage, whether it's from the time of diagnosis or even pre-op preparation or even the post-op management. And too many of these admissions actually can be avoided if we have had earlier interventions. There are three aspects of medical management. One is what is the antimicrobial choice. Two, how do we maintain the hemodynamics of these patients? And three, how do we monitor that we are maintaining the hemodynamics of these patients? IV antibiotics, they play a very, very important role. And it starts with what empirical antimicrobial therapy we are going to use once we suspect a patient has sepsis and septic shock. And to add to this, and more so to us or to most of us who are anesthetists or anesthesiologists, it also depends a lot on what surgical antibiotic prophylaxis we choose for whatever surgery that we have done. It's important to remember that you may have polymicrobial infections, and this is probably the biggest cause of shock and severe sepsis and shock. Remember that there's a dilution effect on that spacing, and this you have to consider with hydrophilic agents. Here we are thinking about the beta-lactams, the cephalosporins, the penicillins, aminoglycosides, and also glycopeptides. So if you have a patient who has significant that spacing, then you must consider that dilution effect. The other aspect to consider is some authorities argue you should start narrow, then you go broad spectrum after cultures. But what is more of a consensus now is you start with broad spectrum antimicrobial regimes. Remember, our patients in this case are very sick, basically complicated, and then you narrow down after you get your cultures. As the de-escalation should be possible in 48 to 72 hours, especially if you are in a good center where you are able to get your culture results in a timely manner. This study, it's called the SMART study, was done not long ago, in 2016, and they were trying to look at the patterns of clinical gram-negative bacilli, the resistance of gram-negative bacilli to antimicrobial agents. And it's been shown that there's very worrying resistance, which is worldwide, and this has even necessitated the WHO to declare antimicrobial resistance a global emergency and a threat to our future generations. Anyway, having said that, you need to remember that higher than standard loading doses of beta-lactams and aminoglycosides are to be used. Remember, we have said this is because they are distributed quite a lot in that space. The loading doses of lipophilic antibiotics, and here we have the macrolides, fluoroquinolones, the tetracyclines, and also the linezolid, which we use for MRSA, are not influenced by the dilution effect. So you do not have to consider that. In terms of the choices we have, depends on several factors. Is it community acquired or healthcare acquired? Is it of mild to moderate severity? Is it of high severity in relation to community acquired? But for the healthcare acquired, I think here it depends a lot on what you grow in terms of cultures. With community acquired mild and moderate, we tend to go usually for single agents. And here you can use ertapenem. I think this is quite readily available, moxifloxacin, or even the tigecycline that we chose. Remember, however, our patient was in the healthcare associated. You can also use combinations, and you use combinations when you're using agents that may not have very good activity against these bugs. I think in our setup, this is what appears more feasible. I know we do use a lot of Zinacef and metronidazole post-op. This is justified, especially if you do not have the severe forms of peritonitis. But once you get now to the severe forms, here you are thinking about the carbapenems, imipinem, or the carbapenems with the cilastatin or with the boosters, or penicillins which are boosted with drugs such as the tazobactam. Alternatively, you may use a combination, and this is probably also what we may be able to employ here. The quinolones and metronidazole, or the cephalosporins and metronidazole are quite a good option. With the healthcare acquired infections, you are justified to go straight on to the carbapenems. Of course, you have to remember that cultures are very important. And when you are thinking about the carbapenems, you have to think about which bacteria you are dealing with. Those that are extended spectrum beta-lactam or lactamase producers, you can use the carbapenems, but remember, ertapenem does not have good action against the ESBLs. Pseudomonas and aeruginosa is a very slippery bacteria to deal with. And this is because it develops resistance very easily once exposed to different antibiotics. You may culture a patient today and they have a pseudomonas that is resistant to most of these drugs, and after treatment with one of them, you find the resistance changes quite easily. Always remember not to forget the MRSA, or the methicillin resistant Staphylococcus aureus. A couple of years ago, we didn't have a lot of MRSA, but we are seeing more and more of MRSA. So it's something we always have to consider. And we know in this case, we have two options. What is probably more available to us is vancomycin, but remember, we can also use linezolid. If we have very resistant bugs that are resistant to the what we call the reserve drugs, mostly tigecycline and coristin, we have had a number of newer agents. I know most of them have not been available locally, but sorry about that. Sorry, I lost the internet connection. Idris, I could be answering any questions as we reconnect.
Yeah, sure. So as you reconnect, there's a question from Farai Mazimba Moto. He's basically wondering on the efficacy of minimum or minimal access surgery, given that if this patient was taken to laparotomy on day one, you probably would have avoided the multiple, theater sessions. And so he was just wondering how efficacious is minimal access surgery compared to, a laparotomy, for example, in controlling abdominal sepsis.
The reason why we had to go for minimally invasive interventions in this patient is because Remember there was the first surgery, which was a TH. There was a laparotomy that was thought to have cleared all the intra-abdominal corrections, but did not. And then subsequently, there was another surgery, also an open surgery. And in this case, they were not able to access the past collection. And this is the time now that we had to resort to. This is the time now we had to resort to minimally invasive surgery. So it is not the first choice, especially when you have complicated intra-abdominal infections. But in our case, it was actually a first option. It wasn't our first option. We did 2 laparotomies initially.
Okay, I think that has been answered. We may proceed with the presentation.
Thank you. So I've mentioned those 2 options in terms of antibiotics. They are newer, and I mentioned they probably were not available, but I understand ceftazidime avibactam is going to be available in this country, probably is already available. And the advantage of ceftazidime avibactam combination is it possesses very good activity against Pseudomonas. Although it does not cover the Klebsiella especially. Pseudomonas is one of the commonest causes of MDR related sepsis. And once you have resistance to coristin, then you have no other option. This is now an available option. Remember also, we have to renodose our antibiotics. This is something we can get in the textbooks, what is the best doses depending on our creatinine clearance of our renal function. In terms of hemodynamic support, we'll go briefly through that. We know that cardiovascular insufficiency is quite common in severe sepsis. It leads to global tissue hypoxia. This could be related both to hypovolemia, dysregulatory dysfunction, or myocardial depression. So we have to emphasize on hemodynamic support in these severely ill patients. There are various ways of monitoring how well our patients have been supported or have been resuscitated. One of them is, of course, lactic acidemia. It's been found to correlate to the level of sepsis or the severity of sepsis, and also has been shown to correlate with the resuscitation measures. You expect your lactic acidemia to improve as you adequately resuscitate the patient. We know about fluid resuscitation. Of course, crystalloids are our first option. But in a patient who is anemic, like our patient, we had no choice but to eventually transfuse. There are a few situations where you can use other interventions, and here I'm talking about albumin. With abdominal sepsis, which also affects hepatic function significantly, most of these patients will have severe hypoalbuminemia. And with these, they tend to have worse healing in terms of outcome, and also that spacing the effusions we talked about in the chest, and also can have significant ascites with low albumins. It's easy, of course, to use albumin when you have other interventions going on, like the dialysis. This is because we know also that albumin can cause problems with your respiration due to flash pulmonary edema. It's also important to remember with intra-abdominal sepsis, we have targets in terms of what is our mean arterial pressure. We can use the current surviving CCSK guidelines. We need to aim at maps of more than 65. CVPs, central venous pressures of 8 to 12. But if you are able to check central venous oxygen saturation, that's even better, should be above 70. And as usual, urine output is very, very important. High intra-abdominal pressures, which is what we basically have in most of these patients, can end up giving you a false elevated CVP. So you always have to remember about that. Of course, we can measure intra-abdominal pressure by measuring intravesical pressures. Let me not go into the details of that, but you need to know you can do this with simple implements. So long as you have a manometer, you have an indwelling urethral catheter, you should be able to measure that. If you have a pressure of more than 12, then you know you are developing intra-abdominal hypertension. And once you are above 20, you are definitely in a compartment syndrome, which warrants immediate release. Abdominal perfusion pressure is a product of the MAP. You minus the intra-abdominal pressures, you should be above 60. There are various ways of monitoring fluid status. We no longer use the pulmonary artery catheters. They are quite invasive to insert and probably even to interpolate is a challenge. I've seen this being used more after cardiac surgeries, complex cardiac surgeries. We can, however, do echocardiography easily, looking at the filling pressures in the atria. And it's even better if you look at this through the esophagus, that is transesophageal. There are more complex systems like the PICO system, the pulse index control continuous cardiac output. This is, of course, a more complex system. And what it looks at is basically just the dilution factor. It's less invasive, does not require intracardiac catheterization. You can do this using a CVC. Lithium dilution continuous cardiac output monitoring is similar, although the PICO uses the pulse index, the LIDICO uses thermal dilution. Most hospitals, I'm sure, may not be able to get this, but I've also seen it in probably one hospital in Nairobi. I'll not go into the details of vasopressor agents, but as per the Surviving Sepsis campaign guidelines, we know epinephrine is our first choice. And if this doesn't effectively sort out our hypertension, then our second option is epinephrine. Dopamine is not used as a first line. We know it causes more tachycardia, and it's definitely more arrhythmogenic than norepinephrine and epinephrine. We can also use vasopressin, usually our third choice in terms of vasopressors. We know it constricts the smooth muscle by directly activating the V1 receptors and increasing the vasculature responsiveness to catecholamine. So it's usually the third inotrope that we add. Inotropic agents, not commonly used. We use dobutamol more with patients who have significant myocardial issues to increase cardiac output, stroke index, and oxygen delivery. It is, however, not used in sepsis. It has been it's known to cause arrhythmias quite a lot, especially in very severely ill patients. Now, in terms of multi-organ failure with abdominal sepsis, it's quite common. Most of the patients with complicated intra-abdominal infection will also get some form of respiratory dysfunction. If not a pneumonia, they'll get a complicated pleural effusion. Kidney, also quite common. As you saw, our patient, we developed AKI, which eventually even required dialysis. Hepatic, in most cases, they get elevated transaminases, but also, as I mentioned, low albumin, and also make sure you monitor the blood sugars because of reduced hepatic glucose synthesis. Cardiovascular, I mentioned this overt myocardial depression once you get severe sepsis, but this can also be related to the fluid status of the patient. CNS, something to remember, our patient did not get that, but coagulopathies are also quite common, Coagulopathies are also quite common, and we have to look especially at the coagulation factors that are related to hepatic function in this case. But this could also be related to our interventions, especially if we are giving lots of fluid, cold fluids, and all that. The gut metabolic, that's also a very important aspect to remember. More than 50% of patients with complicated intra-abdominal infections will develop multi-organ dysfunction syndrome. And we know that multi-organ dysfunction syndrome, even with the best of care, the mortality is quite high. You only have a survival of about 20%. Acute kidney injury and respiratory failure are the two commonest complications that you'll see with complicated intra-abdominal infections. We do not know the mechanism through which injury happens to the kidney. This is especially if you have rehydrated your patient well. So the commonest cause, or the most plausible cause, may be related to the toxins being generated by this severe sepsis. Remember to use corticosteroids as per the Surviving Sepsis Campaign guidelines. 100 milligrams TID is a good dose to think about. Think about nutritional support early. Remember, most intra-abdominal sepsis will also affect the ability of your patient to take orally. We had to use TPNs, parenteral nutrition, for our patient for a prolonged time. She got severe vomiting at some point, despite the fact that we didn't have any obvious features of intestinal obstruction. However, use the gut at the earliest opportunity. Total parenteral nutrition comes with other complications. Not only is it likely to predispose your patient to fungal infections or other bacterial infections, but also electrolyte imbalances such as hypernatremia. I'll not go into the details of source control, but you have to know that the initial surgery is very important. It may be an initial definitive surgery, but you may also want to do damage control surgery. You have to remember that you have an option of doing a laparotomy, especially if you are doing a damage control surgery, then you have to go back. But there are situations where you'll have a laparotomy on demand, and this is where you have developed sepsis after an initial laparotomy. We did 2 laparotomies on this patient on demand. The patient developed overt fissures of peritonitis. There's a new concept that is coming up also in regard to bacteriophage therapy. We know bacteriophages are RNA, DNA particles that depend on bacteria for their replication. And these have been used locally, not intravenously. They've been used locally to eliminate multi-drug resistant infections. Remember also we have the concept of an open abdomen, and this is quite important in 2 situations. One is where you have obvious compartmentalization, and then 2, when you have persistent collections within the abdomen, despite what has been thought to be adequate drainage, then having an open abdomen and giving time for the natural body mechanisms to heal, it can give you a lot of peace. So it will allow me to skip that. So in terms of prognostication, there are several prognostic scores that are available. I will ask us to look at these scores. Some of them are related to leakage scores. Others are related to postoperative peritonitis. This peritonitis severity score, which is just a general score, look at them. The WIS study, which I probably alluded to, has come up with a more simplified scoring system. I'll ask us to look at that. In conclusion, the outcome of complicated intra-abdominal infections will depend on 1, early diagnosis, 2 is aggressive and early optimization of physiology. We have mentioned about hemodynamic stabilization, use of antimicrobials. 3, early surgical management with source control, very important. And then once you get into the complicated septic shock kind of scenario, then aggressive critical care with an appropriate antimicrobial use is very important. The operations are common, and as anesthetist, at times it can be frustrating. You may think the surgeon is not doing the right job, but the abdomen is really a strange place. Never really behaves the same despite even what would be considered very good intervention. I think I'll leave it at that. Get back to you, Idris or Dr. Nganga. If there are any questions, we can answer them now. Idris?
Okay, thank you very much, Dr. Okioma, for this wonderful presentation. I think it's been very clear and it's been well received. There are lots of positive comments from the chat. Is Dr. Okello on? Dr. Okello? Hello?
Yes, Idris, I'm here.
Would you carry on a bit as I prepare to come on? Yeah.
Okay, thank you very much, Dr. Okioma. And I'd also like to acknowledge and thank Dr. Kinyua and Professor the guys who are Professor Manase, the people who are involved in the case, and you've been able to answer some of the questions that have been coming through in the chat. Dr. Okioma, there's another question here. Someone that is Njuguna
Yes.
would like to know what is the potential role for etapenem containing double carbapenem therapy in complicated intra-abdominal sepsis with MDR pathogens. I don't know whether you'll be able to handle that now. Yes.
Yes. There has been suggestions that in situations where you have multi-drug resistant infections, using two synergistic antibiotics, you may be able to achieve a good effect. But I don't think using two carbapenems is really an option, but it's using a carbapenem with another antibiotic. For example, if you have a multi-drug resistant Pseudomonas aeruginosa, that is resistance to colistin, for example, and also resistant, looking at the MICs, sorry about that. Looking at the MICs, you may be able to use both the colistin and the meropenem, despite the fact that they are resistant, and hopefully you are able to clear that infection. But using two carbapenems, I do not think that is a feasible option.
Thank you very much, Dr. Okioma, for that. Now, Fred Fly from Uganda would like to know if this surgery was done in a government or a private facility, and secondly, what cadre of providers were involved in terms of the specialists? Was it an intern, MO, SHO? Would you advise to work on these patients so as to improve outcomes? Because it says from his observation across in Uganda, is that this kind of thing is usually left to the junior cadres, and he thinks this might be leading to bad outcomes. I think this is pretty straightforward for you, Dr. Okioma.
Yeah, this patient was managed by probably the most senior consultants in the hospital. Professor Lema has acknowledged those very senior surgeons, interventional radiologists. It was the best team you could think of, anesthetist, all. So there is definitely likely to be better outcomes when you have such senior experienced members managing complicated infections.
Thank you very much. We have a question. I'm going to ask two of them from Lillian. Lillian would like to know, when is it recommended to start TPN, total parental nutrition? As in, after how many days of NPO would you start TPN? And Godfrey Ngabonziza would also like to know, how do you calculate TPN for adults and peds? Do we have any standard formula for that?
To answer the first question, at what point do you start TPN? If you look at the guidelines, both from the Americans, the Aspen guidelines, and also the European guidelines, the Aspen guidelines, in terms of what are the options for nutrition. If you have a patient in shock, in septic shock, then, or if you have a gut that is not usable, you can't use the gut, then you have no option but to start TPN at the earliest opportunity. I know this may not be feasible in most of our setup, but if you cannot use the gut, if your patient is in septic shock, then don't use the gut, go to TPN. But at the earliest opportunity, then introduce your parenteral, your enteral nutrition, whether it's through the NG tube or orally. In terms of calculating, I mentioned the two guidelines, SPEN and ASPEN. They have very clear calculations of how much do you need in terms of calorie, how much do you need in terms of protein, and how much do you need in terms of microelements. Of course, with the calorie, you get it from lipids, you get it from carbohydrates, and they give you calculations of how much you need. For example, proteins, is it 3 milligrams per kg per day? Then you calculate with that. So there are actually guidelines on how to give TPNs, probably not within the scope of what we can discuss now.
Thank you, thank you. There are a couple of comments and questions concerning this case. We do appreciate that the Nairobi Hospital is one of the best equipped hospitals in the region. And a number of us would like to know, what would you advise those people who are in the peripheral hospitals or in a government hospital without an ICU? How would you think, or how would you advise them to manage this case if they're not as lucky to be in a Nairobi Hospital?
That's a difficult question to answer because this patient needed probably everything that she got in our setup. As there's nothing that was done that she didn't deserve. And probably she's alive because of the aggressive work done by the surgeons and the critical care specialists in this case. What I would say, if you're in the periphery, the best thing is, of course, to recognize that you have a complicated patient. And probably the use of telemedicine, the use of colleagues to help in the management of this patient, because every patient is different. What you need to do for one patient is different from the other. So probably telemedicine is a good option, but also just having the basics of managing these patients as we have discussed today. As in, are you looking at source control? Are you using appropriate antibiotics? Is your patient hemodynamically stable? What have you done? Because these are things that can be done down there. It's probably the surgical aspect that if it's too complex, then needs to be referred to the next higher facility.
Thank you. Dr. Umani is asking, what was the cause of sepsis after hysterectomy in this patient? Did you people get a chance to do an audit on infection control in the theater or in the ICU?
It's probably not clear what was the cause of sepsis, but remember, when you're doing a TH, you're basically in a dirty area, either way. Even with very good sterile technique in terms of surgical technique, it's not uncommon for you to still get sepsis. And there are many reasons why that can happen. It's not necessarily something related to the surgical environment. It could as well be related to patient or host characteristics. It's not clear, but personally, I think this was a viscous, the same way you would get sepsis after an abdominal surgery or after gut surgery. It's not any different.
And finally, before I give you a break, there's a comment and question from Dr. Madina from West Africa. He says that he has seen many doctors in West Africa combine carbapenem with aminoglycoside and metronidazole. Is that advisable, considering that the patient's urine output is good?
It basically depends on what you are treating, and that is why I insisted a lot on the role of having cultures. I'm not sure whether that is empirical treatment or that is definitive treatment, but if it's empirical treatment, then what is the target? Carbapenems do a good cover of gram-negative, and aminoglycoside, as we know, are targeted mostly at gram-negatives. So I'm not very sure. It depends on what they are targeting, and my advice would be base your antibiotic choices on cultures. Otherwise, you'll be just throwing a bullet or an arrow into the dark without a specific target.
Okay. Again, let me thank Professor Valentino Manasse for giving us further information on the chat, answering some of the questions some of us would have been having. Before I hand over to Dr. Idris is going to talk to us a little bit. This CMA was organized in collaboration between the CCSK and the Kenya Society of Anesthesiologists. But finally, Dr. Okioma, Dr. Odaba would like to know whether routine selective digestive decontamination has any role in reducing intra-abdominal infection in critically ill patients. And if so, what regimen would you recommend?
Sorry, the question was selective?
Digestive decontamination.
There isn't much evidence to support gut decontamination or selective gut decontamination during abdominal surgery. Although I'm not sure whether he's talking of, if you are going to deal with intestinal surgery and you want to decontaminate the gut. I'm not sure whether that's what he's asking about. Or because our patient really didn't have anything to do with the intestines per se. It was the abdominal cavity, peritonitis. But there isn't much evidence to support the kind of decontamination that we used to do. I know in our times, even before a hemorrhoidectomy, you would have to basically clear the gut, both mechanically and using antibiotics. So I don't think there's evidence to support selective decontamination of the gut.
Thank you very much, Dr. Okioma. And let me take this opportunity to thank, before we go to the next part of this presentation, to thank all of us joining from all corners of the world, those joining from across Africa, West Africa, Southern Africa, North Africa, Somalia. In the spirit of Ubuntu, we are because you are. Thank you for joining. The ones from India, Canada, Europe, and the rest of the world. Thank you very much. Dr. Idris, maybe you can take over now.
Okay, thank you very much. Would you allow me to share the screen?
Sure, no problem. Dr. Okioma, just kindly bring down your screen.
Thank you very much, Dr. Okello, for this opportunity. This is not another major presentation. It's a very short presentation. Okay, so I'm here to talk about the Kenya Journal of Anesthesiology and Critical Care Medicine. So I believe it is very, very important for us as experts in whatever field of medicine to be documenting what we do. And that's why we came up with this Journal of Anesthesia and Critical Care Medicine. Our objective basically is to provide a platform for researchers and academicians to share, promote, and discuss crucial topics in the various areas of practice. So basically, we intend to document the things that we do, especially in anesthesia, things like ambulatory anesthesia. We need to start sharing things like a documentation of what you do and the workflows. We need to start looking at books. We need to start publishing books, and we should be reviewing our own books. We need to talk about various aspects of clinical anesthesia. In Kenya, we have a fellowship in pediatric anesthesia, which is supported by the WFSA. We should be having a lot more documentation from the whole process. We have cardiac anesthesia, we have obstetric anesthesia. We should be documenting all these processes. I've seen lately there's the concept of sharing data analysis so that we can promote something called the reproducible research. So if I do gather data and I analyze it, people can scrutinize what I have done and maybe make constructive, criticism. So we have to sort of standardize the way we report what we do. Through this, we have been able to set up the Kenya Society journal, which is called the Journal of Anesthesia and Critical Care Medicine. The inception was sometime in 2017, and we've had roughly, 10 issues, all right? But our biggest problem is the, publications. We are sort of lagging behind because we have very few articles per issue. For example, if you look at our average, number of articles per issue is probably 3 or at most 4. So I was hoping to use this opportunity to request members of the Kenya Society of Anesthesiologists or the Critical Care Society of Kenya, to use this opportunity to, document. And because much later, when you call yourself an expert, there's need for evidence. It is a good thing to publish because look at our, readership. When you started around 2018, towards the end of 2018, we would get only 50 downloads, but you can see we have been increasing our readership up to maybe nearly 300 downloads per month. So I'm really appealing to members of the society to, help us build our, documentation process. And we are very fair in terms of, our review process. It's double blind. So you don't know who you're reviewing, and the reviewer, the person who's being reviewed doesn't know who is reviewing him. Most of the time we make a decision in about 5 days. We only reject a few papers. But the fact that our submission rate is very low, we make very few rejections. And the median time to publish is around 4 weeks. All right. So we are hoping that we can have more publications and people from, all over the globe, starting with Africa, you are welcome to publish in our journal. Thank you very much.
Thank you very much, Dr. Idris, for that. So for our colleagues in other fields, feel free to publish. For our friends across the continent and the rest of the world, as Dr. Idris has said, you're more than welcome to share with us. I know there's a lot going on out there that we could share and all benefit from. Dr. Nganga, are you still with us, or you are sorting out an abdomen? Probably Dr. Nganga is busy. So I'll take this chance finally to thank all of you for attending this session that was organized by the Kenya Society of Anesthesiologists and the Critical Care Society of Kenya. Thank you for your participation, and we hope to see you again next week, Thursday, same time, same place. In the meantime, some people had asked where they can get these talks that we've been having. Kindly log into the websites of the Kenya Society of Anesthesiologists and the Critical Care Society of Kenya. There will be links there for you. You'll be able to read or listen to these presentations. So you don't have to worry about taking snapshots or photos during the discussion. Just listen. If you need to look at it again, we will share this with you. And with that, I'll finally thank the team from Nairobi Hospital for sharing this with us. Thank the hospital and the patient, who I'm sure must have given consent for this to be shared, and all of you for your contribution in this academic venture. As we go from here, maybe some of us will be able to handle these patients better. I can see one of us already saying he's been called to anesthetize an abdominal patient and is already rushed out. Otherwise, goodbye. Have yourself a good evening. God bless.